Healthcare is currently experimenting with two separate approaches to artificial intelligence, and the data shows they are producing wildly different results. The first approach uses general-purpose large language models as conversational symptom checkers for the public. When tested for medical triage, these conversational models average 76% accuracy. For a diagnosing patient, that implies a 24% clinical error rate. The second approach is the GPND-AI classifier, a model built specifically for clinical use. This system distinguishes 4 complex neurodegenerative diseases with 92.3% accuracy, using only a 10 microliter blood sample. The performance gap suggests that clinical utility depends on the source of the data, whether a model analyzes syntax or human biology. To understand the value of a 92% accuracy rate, we have to look at how these diseases are diagnosed today. Doctors typically rely on subjective cognitive tests and high-end neuroimaging. Detecting amyloid plaques and tau tangles currently requires A-beta and tau PET scans. This hardware is expensive and limited in availability, which creates a significant barrier to early diagnosis. Standard assessments also tend to force a single binary label onto a patient, which rarely reflects the messy reality of the aging brain. Because traditional tools struggle to detect overlapping invisible diseases, there is a clear demand for a non-invasive, scalable solution. Researchers at Penn State University recently conducted an in-the-wild evaluation of large language models. They ran 212 health queries through 4 different systems and had 9 board-certified physicians grade the responses. This chart shows the accuracy rates the physicians recorded. GPT-4o performed best at 84.6%. But the reliability is not consistent across models. Accuracy for Llama 3 8B fell to 50%, which is effectively no better than a random guess. The lowest validity scores appeared in queries related to internal medicine, neurology, and dermatology. The team also tested retrieval-augmented generation, feeding the models a curated medical knowledge base. Surprisingly, this did not significantly improve the clinical results. This highlights a structural issue. LLMs are designed to predict the most likely next word in a sentence. They are calculating syntax, not performing a diagnostic analysis of biological facts. That consistent error rate makes generalist LLMs a liability when used as a primary filter for patients. The Washington University GPND-AI classifier avoids this linguistic trap by using a different data source, the Alamar Biosciences NuLISA-seq CNS disease panel. This platform uses a specialized immunoassay where target-specific antibodies bind to proteins in the blood. These antibodies have oligonucleotide tags that act as digital barcodes. A sequential capture and release process physically removes background noise, leaving behind only the precise tagged complexes. This process achieves what is known as atom-molar sensitivity, the ability to measure proteins at the femtogram per milliliter level. This sensitivity allows the system to quantify over 120 neurospecific and inflammatory proteins from just 10 microliters of plasma. This highly dimensional proteomic data provides the biological ground truth that text-based LLMs lack. Tracking 120 different proteins is useful for research, but it introduces too much noise for a practical clinical test. To refine the system, researchers used a multi-step workflow, including variance filtering and differential abundance analysis, to identify the most predictive markers. The result is this 15-protein panel, tracking synaptic degradation, axonal damage, and inflammation. Look at the row for p-tau217. It spikes exclusively in the Alzheimer's column. Other proteins are equally selective. MME targets frontotemporal dementia, CRH identifies Lewy body dementia, and Park7 tracks Parkinson's. By isolating these 15 proteins, the AI can mathematically define the biological state of the brain from a simple blood draw. This precision addresses the core diagnostic flaw we identified earlier, the fact that human aging often involves more than one disease at a time. Instead of a simple yes or no, the GPND-AI outputs joint probability vectors across 5 categories. This allowed a significant clinical discovery in patients diagnosed with Parkinson's, who later developed dementia. Clinical assessments missed the cause, but the AI detected Alzheimer-like biological changes. By using mathematical probability, the AI can map the overlapping complexities of neurodegeneration that standard clinical tools often overlook. The 20% error rate of large language models shows that syntax-based AI is not yet a reliable tool for direct patient triage. Contrast that with the 92.3% precision of the GPND-AI. This shows the result of applying machine learning to quantitative biochemical data. AI in medicine is not a monolith. Its safety and accuracy depend entirely on its design, and whether it is built to analyze human language or human biology. For a deeper look at the Washington University methodology, we've linked the research in the description. And for more technical deconstructions, subscribe to Insight Engine.